Thoracic segment, we work on breathing. Sometimes I have to help patients to breathe by pressing on their chests in exhalation. We loosen the chest by tickling the intercostal muscles or by painful pressure on the intercostal muscles, by hitting and reaching with the upper extremities. And once again, we run into interesting phenomena. A lady who is unable to reach out and call mama, every time she tries to do it, she just bursts into tears. And I say, can you put your hand, close your hand around my hand? And she can't. She can't make that much contact. She can touch my hand, but she cannot close her hand around my hand. The diaphragmatic segment. We work on gagging by, I have the patient swallow a glass of water, and I have an emesis basin, and I say, now stick your finger down your throat, breathe deeply as you do it, and try to gag. And what happens to a lot of people, they put their finger down their throat and go, because the gag reflex has been denied by a superficial cough reflex. And the model for a gag reflex is a 1-year-old infant who, the milk goes down and the milk comes up. And that kind of reflex is lost to many adults who are thereby unable to gag. If you give them Ipecac, maybe, they can vomit. But short of Ipecac, they cannot gag. And we sometimes spend hours at a time just working on loosening this gag reflex, because patients experience a great deal of not only emotional release, because very often when the gag reflex is released, they're for the first time able to sob or to scream, because along with holding that gag reflex is a lot of emotional repression in this area and in the diaphragmatic segment. Then also I have patients do an exercise like Santa Claus. They go, ho, 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 moving this segment, which very often turns into involuntary laughter and then into sobbing. Work on the abdominal segment is generally a matter of either painful pressure in the abdomen or tender stroking of the abdomen to let whatever is held there come through. And to work on the pelvic segment, that's generally an area at which we must spend a great deal of time, because there is a great deal, as I have indicated, of anxiety in that area, and one can precipitate a great deal of trouble if one approaches this segment too quickly or too precipitously. Now, in working on the pelvic segment, one of the first places that we work is the thigh adductors, which I call the morality muscles, the muscles that hold the legs together like this. So we apply painful pressure to the thigh adductors. We also work on tightening and releasing the pelvic floor. And this helps to loosen pelvic armoring. Also in this, working on this area, we do lots of talking about sexual experiences from very early ages, sex-negative experiences with one's parents or one's neighbors or one's family. So it's a period in which a great deal of guilt is released verbally, and in which a great deal of physical work is done orgonomically. If we succeed in loosening the armoring from head down to the pelvis, then there is the appearance of what Reich called the orgasm reflex. The orgasm reflex is an involuntary movement of the pelvic musculature, not only involved with sexual activity, but that is evoked in periods of high emotional excitement. So it's not a purely sexual phenomenon. For example, one of my patients who was an entertainer, a singer, was giving, like in her therapy, she was through to that segment. And she was giving one of the performances of her lifetime. She was really on. And the audience was really with her. And she was in a period of very high emotional excitement. And she said, suddenly my pelvis started to move and I couldn't stop it. And that's the orgasm reflex. And the orgasm reflex sometimes appears in therapy, and it takes sometimes several years before the orgasm reflex becomes incorporated into one's sex life, so that it becomes a regular part of the sexual orgasm as well as just a phenomenon. Reich said that the full orgastic discharge was the major expression of energetic discharge in the human being. Energy can be discharged by thought processes, by physical work, but he thought that the large basic biological discharge mechanism was the discharge in sexual activity. Now, some generalities concerning therapy. Therapy is generally conducted once or twice a week, most often once a week. In times of emergency, we see patients, of course, more frequently. And if there is an incidence of, for example, of panic attacks, we see the patient maybe daily for that period of time. All human emotions are elicited, or attempted to be elicited in the course of therapy, so that usually our offices are soundproofed to the extent that we can keep the neighbors from hearing what's going on. And despite the fact that all emotions are elicited, there is a clear distinction made to all patients that there must be no destructiveness. They must not attempt to destroy me nor my office. That the expression of meanness is not in the service of their emotional development. On the side of the therapist, what we do is we prod painfully, we tickle, we stroke. Something that I innovated with my patients was open-handed boxing. We do this, and it's very interesting what one elicits, because, for example, I am smacking the patient's face, not hard, just gently, but the patient is doing nothing more than come and hitting my arm. The patient is unable to get past this to get to me. So that a great deal is revealed about how aggression is working in that individual when you do some boxing with them. We make angry faces at one another. It's a reciprocal event, therapy. It's certainly not what the analyst does, sit behind the couch taking notes and making comments every once in a while. Because there is so much physical contact in orgonomy, it is made very clear to all of our trainees that there must be a categorical imperative